This program is brought to you by Emory University.
Good morning, everybody, and thank you for joining us. It's my pleasure to introduce Dr. Kalra. Kanika has recently joined us about 6 months ago as a cardiac surgeon at Emory University Hospital Midtown. She will divide her time between the clinical work as well as basic science research. She spent 2 years in our laboratory during her general surgery training at Emory, and then continued on with cardiothoracic surgical training, which she just finished last year. She has a particular interest in valvular heart disease research, right ventricular mechanics, and right-sided dysfunction, which, as you know, we actually know very little about. So we're very excited with innovation and discovery, which we look to her to help us solve some of these problems. So without any further ado, I please pay attention to Dr. Kalra.
Good morning, everyone. Thank you, Dr. Halkos, for that kind introduction. As he said, I just recently joined as faculty, and I'm in the process of building my research program focused on right ventricle and tricuspid valve disease. I have no financial disclosures, and the reason I chose right ventricle as my area of research is because during training, I took care of several patients who developed postoperative right ventricular dysfunction, having normal ventricles or normal-looking ventricles preoperatively, and we strived hard to get them through this acute RV failure phase, which often got me thinking that there has to be a way to identify these patients at risk and avoid this problem altogether in future. So my talk is going to outline right ventricle anatomy and functional assessment. I will then focus on right ventricular mechanics with the use of invasive PV loops, its response to pressure overload and volume overload, and then specifically focus on what happens during tricuspid regurgitation. And then we'll try to identify when is the RV too sick for any tricuspid intervention, and introduce RV-PA coupling as a prognostic marker for this disease. And then I'll introduce a couple of topics that I am thinking about in context of what else we probably are missing in the assessment of right ventricle. So right ventricle is normally just 2 to 3 millimeters thick. It has 3 components: the inlet, which consists of tricuspid valve, chordae tendineae, and the pap muscles. There is trabeculated apical myocardium, and the infundibulum or conus, which corresponds to the smooth myocardial outflow region. Unlike the left ventricle, which has 3 layers of fibers, right ventricle has 2 layers, actually. The superficial layers is arranged circumferentially parallel to the AV groove, and is responsible for the inward bellows-like movement of the RV, which actually forms only minor portion of the whole function. The deep longitudinal fibers draw the tricuspid annulus towards the RV apex, and that is responsible for 80% of the function and is very nicely measured by TAPC. The septum is shared between LV and RV. It has oblique helical fibers that cross each other at 60-degree angles and bring about longitudinal shortening. It is also responsible for ventricular interdependence. And then late infundibular contraction comes from oblique ascending fibers. This is a 3-dimensional reconstruction of both ventricles, showing how complex is the shape of the RV and how massively it changes in a patient who has been experiencing volume overload, and how massively it dilates. This little video will show you the different decomposed motions of the RV, the longitudinal, anteroposterior, and the septolateral motions. And there has to be multiple ways to quantify these. So how do we do function assessment? It is best done with multimodality imaging. whereby the CT and the MRI usually are able to provide us volume-centric measurements. The right heart cath can provide us pressure-centric measurements. But let's be practical here and focus on echocardiography, because that's the most common test that is available to us today. So using 2D echo, we can measure the size and the shape of the RV. We can measure tap scene on M mode. We can measure fractional area change on a 4-chamber RV-focused view. We can perform tissue Doppler studies and identify RIMP and S prime. And then most recently, we can do RV strain and even 3D volumes and ejection fraction. So TAPSE is the most commonly used parameter that you will come across in majority of the studies. The abnormal threshold is less than 17 millimeters. It is easy, fast, widely available, and basically assesses the longitudinal motion of the RV. Next is the next most common one is fractional area change, the abnormal threshold of which is less than 35%. It is heavily dependent on image quality because you need to get the RV focused view on 4 chambers and has poor reproducibility. And then 2D longitudinal strain also requires pretty good image quality and has shown in several studies to be prognostic in outcomes. So for example, this study, which looked at patients with secondary tricuspid regurgitation, where RV dysfunction was defined as a combination of TAPSE less than 17 and clinical signs. And TAPSE alone in combination with clinical signs was able to predict survival in these patients. This is another study which looked at both TAPSE and fractional area change. And what they found was that RV strain is actually incremental to fractional area change in TAPSE in predicting all-cause mortality. Next, we move on to 3D echocardiography. 3D EF is increasingly becoming very sought after parameter that we use to assess RV function, because it can essentially incorporate all different motions of the RV. The abnormal threshold is less than 45%. Again, 3D echocardiography is best done in experienced hands and also heavily dependent on image quality and requires training and post-processing. So this is another study that shows that 3D RVEF has prognostic values in predicting outcomes which are independent of LVEF in patients with valvular heart disease. So the problem with all of these parameters are they are very load dependent. So if a patient has been on diuretics, their measurement will be different today versus several days later when they have been severely diuresed. So what are the load independent parameters that can be used? Traditionally, pressure volume loops have been the gold standard of obtaining load independent measures of ventricular contractility. The first RV pressure volume loop was performed actually in Johns Hopkins by Lowell Mon, where they showed that it was feasible to do and it would change in response to several drugs. How are they measured? So usually a 7 French conductance catheter is introduced via a sheath in the internal jugular or common femoral vein. It is positioned over a J wire using Seldinger technique. The catheter has a solid state pressure sensor in the middle and an array of 12 equally spaced electrodes at its tip. So an electrical current is introduced through this catheter, and the voltage drop between these segments is directly proportional to the cross-sectional area, which will be used to measure segmental volumes. And an addition of these all segmental volumes will give a total ventricular volume. You can see here at the bottom, this last segment, this loop is not counterclockwise, so will be excluded from the estimation. It just shows that this is outside the ventricle. So a normal RV-PV loop has four discrete phases: the filling phase from passive to active, isovolumetric contraction phase, the ejection phase, which is pretty domed and actually even continues later into end systole, and the isovolumetric relaxation phase. The width of the loop denotes the stroke volume. The height of the loop will tell us the maximal PA systolic pressure. RV and LV-PV loops, as you can see, are pretty different. The LV peak pressure is way higher than RV peak pressure. RV ejection continues beyond end systole. LV elastance is way higher than RV elastance, but their diastolic properties of note are pretty similar. So this shows that how the shape of the PV loop actually even changes when you expose it to incremental increases in pulmonary artery pressures. It goes from being triangular and low pressure on normotensive individuals to becoming quadratic, trapezoid, and eventually notched in patients who have very high PVRs. So RV systolic properties are determined by what is called the end systolic pressure volume relationship. It is obtained via a family of loops that you can create by altering the preload either with a IVC balloon or Valsalva maneuvers, or even single beat measurements are also being done these days. So the slope of this end systolic pressure volume relationship gives us RV elastance, which quantifies RV contractility. We can also measure preload recruitable stroke work, which actually is slope of stroke work versus end diastolic volume. And it is pretty volume and load independent indicator of RV function, and has been shown to be correlative in of RV contractility in patients with different phenotypes of pulmonary hypertension. So PV loops are actually superior to echo and hemodynamics in terms of measuring RV contractility. This study very clearly shows that they were able to get differences in RV contractility by performing PV loops even before or even when conventional imaging or hemodynamics was not able to identify any difference in RV function. Then we can also look at RV diastolic properties, which is the end diastolic pressure volume relationship. It is nonlinear and passes through the point of end diastole. Specifically in patients with heart failure with preserved ejection fraction, where you can see that the contractility actually is not very different in these patients, but the RV stiffness is increased in HFpEF patients. So that is why they have decreased stroke volume despite a hypercontractile ventricle. We can also look at RV energetics, which is quantified by taking the area within the PV loop, which is the stroke work, and then the area outside the PV loop, which represents potential energy. And the total pressure volume area is proportional to the myocardial oxygen consumption. This figure here shows adaptation of right ventricle to pressure overload. So if you increased PVR from 2 to 8 Woods, you would see that the RV PV loop actually starts to look like LV PV loop. The stroke volume decreases and the pulmonary artery systolic pressure increases. Whereas in volume overload, if let's say you subject the RV to acute tricuspid regurgitation, you would see that the width of the pressure volume loop increases and there is blunting of the isovolumetric relaxation and contraction phases. The PA pressures would drop. Now, traditionally, we have all been taught that RV is super sensitive to afterload, whereas it can take volume overload pretty easily. And we have all seen this figure from a very famous textbook, which shows that even with small increments in pressure, the stroke volume drop significantly in the RV. However, is that really true? If you pay attention to these graphs, what you will find is that the response of RV to afterload is a function of the pulmonary vasculature. And the two ventricles see very different kinds of vasculature. So, but if you compare their sensitivity to afterload in terms of relative changes in vascular resistance, you will see that to get the same difference in stroke volume in right ventricle, you need to increase the vascular resistance to up to 1400% as opposed to 1200% in left ventricle. Similarly, if you looked at the ventricle's chamber pressure, which is a marker of wall stress, and you plotted it against a function of percentage changes in the peak pressure, the RV and LV actually behave pretty identically to afterload. Similarly, as we have overestimated the sensitivity of RV to pressure overload, we might be underestimating the response of RV to volume overload. This is a study by Shah et al. Done back in 2000, where they introduced acute TR in a canine model and measured PV loops. And you could see that there is even 1 week of acute TR caused a depression in contractile performance, along with dilation of the RV and elevations of its end-diastolic pressure. They also correlated that to increase in beta-adrenergic receptor signaling, which also was increased within 1 week. So if you look at a normal RV, how does it respond to progressive tricuspid regurgitation? You can see that the stroke volume and stroke work increases, and so does the PV loop, the total pressure volume area, which means to get the same stroke volume, you are expending more energy if you introduce tricuspid regurgitation. And this behavior is further accentuated when the RV is dysfunctional to begin with. So here you can see that the stroke volume nearly doubles, the stroke work increases despite a reduction in cardiac output, and the TR imposes a significant energetic penalty on the right ventricle. This is another figure that shows that the ES-PVR relationship is the steepest with pressure overload, whereas it's not as steep with volume overload, showing that the RV can maybe adapt to pressure overload and respond with increased contractility just fine. Whereas here you can see that as we are increasing load on the ventricle, there's a increased response in contractility only to a certain extent. And when we bring about reduction in volume overload by, let's say, correcting TR in this particular scenario, we will improve contractility. You can see here there's an increase in TAPC, significant increase in TAPC as shown by triluminate trial after doing tricuspid valve intervention. So if RV is supposed to get better after fixing TR, why is it that we see acute RV dysfunction when we correct TR? In the acute phase, what is happening is we are essentially acutely increasing afterload on the RV. So here you can see on the left, the PV loops in purple shows when you have repaired the tricuspid valve, and the yellow shows when you have actually replaced the valve and abolished tricuspid regurgitation completely. So what has happened is eventually stroke volume has decreased. The overall PV area has increased. That means there is increased oxygen demand on the myocardium, which is leading to eventually relative RV ischemia. And once you get into this cycle of ischemia, your contractility decreases, your stroke volume decreases, and your peak pressures decrease, and you enter a low cardiac output syndrome, which is hard to get out from. This is also seen in the surgical world, where valve replacement actually shows decrease in RVEF as compared to annuloplasty. So how do we identify patients which will benefit from TR correction? Are we doing this too late in the game, or do we need better estimates of RV function? So this is a very elegant study that has shown that patients who benefit from transcatheter tricuspid valve intervention are the ones who have somewhere mid-range RV function where their TAPC is between 13 to 17. The ones who had further reduced TAPC or preserved RV function did not actually see a benefit. Then a new concept of RVPA coupling is also being introduced as a load independent marker. And conceptually, what it tells is whether the mechanical stroke work generated by the RV is efficiently transferred into pulmonary vasculature. It is calculated by the ratio of ventricular elastance and pulmonary arterial elastance. Traditionally, it was always measured with an invasive PV loop, but now there are some non-invasive surrogates that can be measured with echo of this parameter that are being used. The most common one being used is TAPC over PASP or RVSP. This study showed that patients who had higher TAPC over PASP ratio, which means they had preserved or higher RVPA coupling, showed a better survival in patients with tricuspid regurgitation as compared to patients who had poor coupling. And this study showed that a ratio of greater than 0.4 was associated with decreased all-cause mortality in patients undergoing transcatheter tricuspid valve intervention. However, patients who had high coupling also experienced a decrease in TAPC and an increase in pulmonary artery systolic pressure because of increased afterload imposed on the ventricle following tricuspid intervention, which means that patients who came in with high coupling eventually developed lower coupling, which is not necessarily a bad sign. It is just a function of changing their afterload. So with baseline high coupling, they had higher chance of survival, and patients who showed decrease in RV coupling after the procedure had a higher chance of survival. This parameter is now being used in several other valvular diseases as well, like aortic stenosis and mitral regurgitation as an indicator or prognostic factor for outcomes. But if you carefully look at the study from tricuspid regurgitation intervention, patients with high TAPC to PASP still had 9.6% mortality, which is, I think, still pretty high, especially in the surgical world. So are we still missing something, or do we need better parameters to assess RV function that can help early intervention in these patients? What about RV stress testing? This is a concept that has been previously used in pulmonary hypertension patients, but maybe we should test it in patients with valvular heart disease. So as we know that a healthy RV has a great contractile reserve. So with several increasing stages of exercise, the ESPVR rises. And if you come to think about it, when we measure PV loops in a supine condition, they have limited applicability because what is the most common symptom that patients present to us with valvular heart disease and heart failure? It's exercise intolerance. So we need to know what is happening to those right ventricles when they are being exercised. This is a conglomeration of studies done by Dr. Conwell at Colorado and the Columbia group as well, which shows that a healthy RV has substantial contractile reserve, but in a HFpEF patient, there is definitely increased stiffness in these patients, versus in HFrEF and patients with LVAD, there's basically no contractile reserve in response to exercise. As I mentioned before, dynamic exercise testing has been used in patients with pulmonary hypertension, but introducing that in patients with tricuspid regurgitation or mitral regurgitation, and maybe doing a stress testing of the RV using dobutamine preoperatively might give us better insights into what is actually happening. And it might help us identify patients who will not do very well with intervention later on. Another thing to think about in this whole RV function scenario is, are we forgetting about the right atrium? The entire right heart is actually a function of right atrium, ventricle, and the pulmonary artery. So we need to look at all three together. A normal right atrial PV loop, as you can see here, has a figure of 8 shape. It has a passive limb and an active limb. The passive limb basically depicts transition of blood from right atrium to right ventricle at the beginning of atrial systole, and the active limb represents active atrial contraction at the end of systole. When there is RV dysfunction, you will see that the RA PV loop also turns up rightwards and upwards, and the active limb becomes more prominent. What happens to the right atrium with progressive TR? So with increasing amounts of tricuspid regurgitation severity, there is not much change in the function of the right atrium. But if you superimpose right ventricular dysfunction on top of that, you will see that the active limb of the right atrium actually becomes very prominent, which means that the role of the atrial kick that is required for forward cardiac output becomes very important. And so probably does the role of sinus rhythm in order to get that atrial kick. So what basically we can derive from this is that TR does not change the systolic or diastolic properties of the right atrium on its own. But if you superimpose RV dysfunction to it, it accentuates the active limb, provided there is sinus rhythm. This is a study that shows that invasive 4-chamber PV loop analysis is actually feasible and was done in a patient during and after TAVR. So it gives a more comprehensive picture of the whole heart such that all parameters can be optimized and seen. So what we would ultimately need is a comprehensive parameter that represents the whole right heart function. I did a little bit of math in high school, so I just came up with this equation, which I'm not sure if it's even if it even fits to define right heart function, but maybe a summation of right atrial and right ventricular contractility indexed over pulmonary vascular resistance, where X, Y, Z are variables which we need to identify by further research, is what we need to assess the right heart as a whole. So in summary, hopefully I've convinced you that RV has a complex shape and very complex 3 different kinds of motion, capturing all of which with one imaging is impossible. So you need multimodality imaging to quantify the entire RV function. Invasive pressure volume loops provide deeper insights into RV function and also provide load-independent parameters, of which RV-PA coupling is emerging as a novel prognostic marker for outcomes after valvular interventions. Stress testing to assess RV reserve can help provide further insights, and ultimately what we need is a more comprehensive parameter that represents the whole right heart and includes right atrial contribution, right ventricular contribution, as well as resistance from the pulmonary arteries. Thank you. I will happy to take any questions.
Thanks, Kanika, for that nice summary. Is there any questions from the group?
This is Robert Guyton. Have we done has anybody done simple stress testing like leg elevation during echo or during pressure volume loop measurements to, in a simple way, determine RV function?
I have not come across any that simplistic way of testing exercise response to RV. What I did come across was actually bike riding with a PV loop catheter in place in an athlete, which showed exercise response on a PV loop. And then the chemical stress testing as performed by dobutamine that has been used in patients with pulmonary hypertension.
And just a historical note, Dr. Kichi Sagawa, who was the co-author on that 1979 paper from Johns Hopkins, was a biomedical engineer from Japan, taught by my father for 10 years. And then he was hired at Hopkins, and he started the bioengineering department at Hopkins. And he's a co-author on that paper with Myron Weisskopf on the RV function and the pressure volume loops.
Stan Sherman, just I'm impressed that we have somebody now who understands all these pressure volume loops. But basically, has there been any work done with some of the lesser invasive techniques than the full valve repair, or in other words, stitching some of the or connecting some of the tricuspid valve together to just be a lesser technique?
Nobody has looked at RV functional changes after doing a lesser invasive repair, but there are several studies of doing lesser invasive tricuspid repair, like an Alfieri stitch on the tricuspid valve. But I'm not aware of any studies that have looked at response to the right ventricle after such a repair.
Thank you for being.
But it seems to me that we have an opportunity, because in 1979, we didn't have MRI. We didn't have other measurements of RV volume. We do now have MRI, and we can alter RV volume simply by compression of the patient's legs, or you could put one of those G suits on the patient's legs and infuse volume into the heart in the MRI machine and change RV volume acutely and measure RV function. You need a PA catheter or some measurement of PA pressure, but if you had PA pressure and changes in RV volume, then you could get an RV pressure volume loop without the catheter, the multi lead catheter in the PA, and potentially use devices that weren't available in 1979. And I think there's an opportunity to begin looking at that. Who are the world leaders in this? You talked about Columbia and Colorado. Are those the two world leaders?
Also MUSC. Dr. Tedford from MUSC is very passionate about PV loops in pulmonary hypertension patients. I did come across
is that South Carolina or
yes,
Southern California?
No, South Carolina. And I did come across actually a study where they did MRI as well as wall pressure measurement simultaneously on a patient by changing their volume load.
Any other comments or questions? I guess one question, Kanika, I have is, what's the next steps here with regards to treatment or intervention?
With regards to treatment and intervention, first of all, we need to identify when should we treat, because I think we are falling behind the game in terms of recovery of RV and after valvular interventions. But if we do get into RV dysfunction, I think there needs to be devices that can probably alter RV contractility by altering its shape. We already have assist devices available that can help us get through the acute function, but I think we need more therapeutics which are targeting directly RV contractility and not just emptying it. And with respect to early recognition, I think we should definitely try to perform some sort of RV stress testing routinely in patients who have valvular heart disease. And I think that will give us much better insight into what are we going into. And eventually, hopefully, that stress testing, if incorporated as a standard of care for everyone, we can identify patients earlier who can be referred to us, to either us or our interventional colleagues for interventions earlier in their disease process.
Kanika, it seems to me like, not only for valvular, but just understanding RV better in general, even for people who, complain of dyspnea to us, for example, obesity, HFpEF, pre-HFpEF. There's so much, I feel like we focus a lot on the LV.
Yes.
Just learning about RV in general seems to me like there's probably a lot of unexplained symptoms that we have that we sometimes, probably miss because of this.
Absolutely.
This is Robert Guyton again. I would urge our cardiology colleagues to consider the difference in treatment between congenital patients and adult patients. In the congenital world, when the RV is 150% of the LV, then intervention on the pulmonic valve or the tricuspid valve may be performed even without symptoms. But in the adult world, we wait until we have symptoms, and the RV then is 200% or 250% of the LV, and we have hepatic dysfunction and renal dysfunction, and we're just waiting too late. I really think we need to be thinking about the lessons from the congenital world about as the RV enlarges, when it reaches a certain level, we need to be thinking about correction of the tricuspid regurgitation in particular when we get to 150% of the LV, particularly in the atrial fibrillation created tricuspid regurgitation situation.
Are there any other questions, comments from the group? Okay, if not, then thank you so much again, Dr. Carla, for doing this for us this morning. Don't forget to get your CME credit, everyone, and I will see everyone next week. Thank you.
Thank you. It was my pleasure, and thank you for the opportunity.
The preceding program is copyrighted by Emory University.